I'm Barb Schwartzberg. I'm at a local community hospital. My patients also thank me. I want to give one caveat before I started. This is my classic patient. Professional lady, attorney, comes to see me, decides to go for IORT, takes one day off, gets surgery and radiation, goes back to work the next day, never tells her employee that she has breast cancer. So think of that, what a different paradigm shift that is for our patients who are struggling to live with their normal lives and still going through this. So Dario, Dr. Franciscotti, called me December 12th, 2010, wanting to talk to me about IORT. Next year, May 25th, 2011, we presented it to the tumor board where I work, Rose Medical Center. July 15th of the same year, the hospital, and it is an HCA hospital, bought the Zoff system. Not only did we put in the PO, we actually had it on the dock. September 24th of that year, I submitted my RB submission to our local IORT, asking for a clinical trial to include 50 patients. October 31st, we got approval. November 2nd, we did our first case, 11 months. Now, I know what you guys are thinking. There's that 6 months gap in there. Obviously, she wasn't really convinced that we should go ahead and do this. Wrong. I broke my leg skiing February 16th, 2011. And I know you didn't think you'd see any ortho during this meeting, but you can see this nice tib-fib fracture down there. I had immediate rotting, pinning, did surgery on a scooter with a Mayo scan covering the scooter handlebars, saw patients on crutches, and still got this thing running in 11 months. So I don't want to hear from anybody that you cannot get this done in your hospital because I was able to do it with a broken leg. So what kind of hospital am I in? We are basically the private practice teaching arm of the University of Colorado. It's a 200-bed hospital. We actually have 30 ORs, so we're a big operating machine. We don't do trauma. We do a lot of cancer. We have a very supportive administrative staff. Here's the cancer committee that I work with. We're all good friends. We have a very collaborative practice. There are years where 48% of our breast cancer patients are on clinical trials. We are the home of Steve Parker and the Mammatome. That was developed in Denver. We had some of the largest enrollment in the NSABP B27 study. We like to do trials. We're very progressive. Our administration strongly supports that because it drives business. Every time we do one of these new rollouts, we really see business pick up. Right now, even in this tiny private community hospital, we do 300 to 500 newly diagnosed breast cancer patients a year. They come from about 5 states. And since I started the IRT a little over a year ago, I am seeing so many patients from PCPs that I have never heard of, that I know it's really building my practice and that we reap a great reward just on reputation. So what kind of patients are we looking for? What was our inclusion criteria when we wrote this study? First of all, we decided we'd go for women older than 40, and that's pretty young. Why did we pick 40? We already had a large clinical trial that was doing immunomodulated radiotherapy for accelerated partial breast radiation. Their cutoff was 40, so we thought we would compete with them and draw from the same patient population. Single cancer, obviously, was important. We selected only infiltrating ductal carcinomas. We decided we would stick with sort of target trial criteria. The cancer would have to be at least 2.5 centimeters on preoperative radiographic imaging. If it turned out to be larger on final pathology, we did not change our treatment. They still got the IRT if it all worked. And we did do a very extensive preoperative mammographic, ultrasound, and bilateral MRI evaluation, making sure that we had a good patient selection going into this. Well, conversely, what were our exclusion criteria? We did not allow for lymphovascular invasion. We did not allow for extensive interductal component. nor metastatic disease, mainly sentinel lymph nodes, or the X-ray lymph nodes had to be cancer-free by preoperative evaluation. We didn't want a patient who had a previous history of either breast cancer or radiation to that breast. We didn't want any patients that had neoadjuvant therapy, either chemotherapy or endocrine therapy. No pregnancy or lactating patients, and no scleroderma, no active lupus, and no ipsilateral pacemaker placement. So I think pretty selective criteria. Even with that, we were enrolling 1 to 2 patients per week in our trial. Right now, a year and a half later, we're probably enrolling 3 to 4 patients in the larger multi-institutional trial. I think this has been reviewed. What do I tell my patients when they come in? Why should they get this? I talk about the evolution, starting with the whole breast radiation therapy as an alternative to mastectomy. Then in Denver, about 10 years ago, we started doing accelerated partial breast irradiation, either with interstitial therapy, the brachio balloons, or immunomodulated therapy. And now we've moved on to the IORT, the intraoperative radiation therapy, as the rationale for how to best do treatment for these early cancers. And it goes from 6 to 7 weeks of therapy to 5 days twice a day to now an 8 to 12 minute episode in the operating room. I think we already know we have an accent controller. I tell patients it looks like a big carpet cleaner. They can identify with that. We have balloon applicators that use a mini X-ray source to deliver the radiation. Just a little bit, I'm not the physicist, but it's a high vacuum X-ray tube technology delivering a 50 kV operating potential, a 35 kV therapeutic delivery. I think what's key to us, it delivers about 1 gray per minute in the surrounding 1 centimeter area of tissue in the breast. We're told it's equivalent to the iridium 192 beads. It's fully disposable, and it's actually FDA cleared for use anywhere in the body. And here it is all hooked together. You can see the controller. This is the docking arm. The balloon is docked to it, and then the mini X-ray source gets slid through that balloon while it's in the patient to deliver the electronic beam radiation. I think the beauty of this, no longer do you need bunkered radiation rooms covered with lead that are millions of dollars. No longer do you endanger personnel with iridium beads. We just step out for a quick break in the substerile room while the radonc people do their magic with delivering the single dose, and then we get back in and finish the case. We do a pretty thorough radiographic workup, ultrasound, MRI, good mammograms identifying that we have a single focus, getting the measurements, and then start the procedure. Basically, here's the localizing wire the patient's already had, her technetium sulfur colloid injected a couple hours prior to the procedure. I still use the lymphozyme blue. We dissect out the lymph nodes, send them down to pathology for intraoperative touch prep cytology, make sure that the lymph nodes are cancer-free by that modality. Then we do the lumpectomy, taking a look at margins. Here I took a little bit more skin to really make sure I had a healthy margin. We get a specimen radiograph in 2 orthogonal views. Here I think this was a little bit close. You can see the clip there. The other clip is right there. I took a little more tissue here just to make sure I got around it. In our protocol, if we didn't get margins, the patient had to get 5 weeks of whole breast radiation. There was no option for re-excision. So pressure was on for me to get adequate margins to allow this patient to just get 1 dose of radiation intraoperatively. And here we are during the procedure while we're taking a little quote-unquote coffee break. The radiation oncologist is there. The machine is docked to the patient. We've got the little flexi shield covering. We have separate drapes over this area while we're doing the procedure. That's all then flipped off and removed, and the treatment is completed in a standard fashion. Here, I'm done this same patient, 2 little stereostrips and tegaderms, and she's off to the recovery room and then maybe back to work the next day. So let's look at our data. I really try to break this down for you. We enrolled 51 patients with the full intent for them to go to the operating room to receive IORT. They met all inclusion criteria. Of those, early on, we had 1 patient where we had technical difficulties. In 5 additional patients, we found that they had positive intraoperative sentinel lymph nodes, and those 5 did not receive IORT. In 3 additional patients, and we had a little run of this, we found microscopic disease, about 2-3 millimeters, in the sentinel lymph nodes after the patients had completed their treatment along with the IRT, and those patients did go on and get whole breast radiation. With only 2 patients out of the 40 that completed the IRT did we have positive margins. 1 went back and had a re-excision and then whole breast radiation. The other lady actually ultimately had a lot of DCIS and required a mastectomy. But that's only 2 out of 40 completing it. The numbers are good. So I really think if you have a good radiographic workup and take your time during this portion of the operating room, you will get good margins, and this is not a problem. So out of that, 40 patients completed the IRT per our protocol. That's 78%, and they're now in our follow-up program. All right, a busy study, but let's compare these 2 groups, the patients that did get IRT versus all the patients that entered the trial. 51 patients entered, 78% or 40 patients completed the IRT. Average age was about the same for both, 64 years old. Average size of tumor was about 1 centimeter. We had an invasive ductal carcinoma on final pathology on 96%. 2 patients actually on final pathology had invasive lobular. We got great margins on both those patients, so we kept them in the study. And then grade. Well, the grade's kind of what you would expect. Actually, in both groups, about 40+% were grade 1, 29 to 30% were grade 2, and 27% were grade 3. So we really ran the gamut on grade. These were not all tiny little grade 1 tumors. To continue with that thought, let's look at the procedures of how we end up dealing with these cases. Average total procedure time, and this is skin to skin, including the IRT, took 1 hour and 47 minutes. It's not the 3 hours, not the 4 hours that you think. We kept right on our day with a normal clip, doing all the cases that we normally would have expected to do pre-IORT, where we just did a lumpectomy with a sentinel lymph node biopsy. Average balloon size, once we figured out how to use these balloons, almost everyone got the small balloon, the 3 to 4 centimeter balloon, 92% did. A couple early on required a larger balloon. Average balloon fill, 32 milliliters. Average radiation dose, we accomplished our goal of 20 grays with absolutely every patient except the one that had technical difficulties. And the average skin to balloon distance was 1.21 centimeters. We're in Denver. We are the lowest obesity patient in the nation. We have skinny little gals, and we still were able to accomplish that skin to balloon distance. Sometimes I'd move the arm down, we'd roll it up, whatever it took, we got it and documented it by ultrasound during the procedure. All right, patient characteristics. Number of lymph nodes that we took, 2.2. Margins. Now remember, I was under pressure. There were 3 of us doing these, but I did a lot of them. If I didn't get margins, this lady was getting 5 weeks of whole breast radiation, and I was going to get shot when I saw her in the post-op. So only 2 patients had less than 2 millimeter margins. One was against the pectoralis fascia major muscle. Another was so clear-cut at 1.7 millimeters. I mean, the cancer just stopped there, that we felt that was satisfactory. And actually, 42% had margins that were 2 to 10 millimeters. The average in this group was 6 millimeters. I have to admit, over half had margins of over 1 centimeter. It's kind of old-fashioned, but I got the job done. They didn't have abnormal margins. They got their 1 treatment, and they went on with their lives. They are very happy. Prognostic factors. I broke this down. And as you would expect, 82% were ER/PR positive, HER2/neu negative. 7.5% were ER positive, PR negative, HER2/neu negative. We took all comers, folks, and we knew this going into the study. One patient was actually ERPR negative, HER2 neu positive, and now has completed a year's worth of Herceptin, along with 4 cycles of Cytoxan and Taxotere. And 3 patients were triple negative, 7.5%, and got standard chemotherapy after the fact. Oncotype DX score, we looked at this. I think kind of as you would expect, 68% were in the low-risk group, 29% were in the intermediate group, and 1 patient with a dear little 7-millimeter tumor had a score of 34 and ended up with chemotherapy. So again, we're doing all comers, and we're going to see what happens with this group. All right, adverse effects. We did have 3 infections. Now that's out of all 51 patients, not just the 40 that got IORT. A little higher than I would like. You can certainly be impressed with, after the fact, as Mel said, a couple weeks later, that skin is pink. You can tell something's going on. And patients that are more used to seeing whole breast radiation, look at that quarter spot of pink, think they have an infection. You know, when in doubt, we would give them antibiotics. 3 really did have straightforward infections. Seromas. I started measuring seromas when they started coming in for post-op, because the big thing we kept on hearing was with the mammocyte balloon, patients would come in 1-2 years later with these huge seromas, and what were we going to do about it? So every patient got my little in-office ultrasound. I didn't charge. At the end of the year, and this was actually 38 patients, only 5 have residual seromas, and they're averaging 1.1 centimeter in size. If I hadn't done the ultrasound, you wouldn't even know they're there. So this is not a problem with this technique. And then cosmetic outcomes. Patients love this procedure. 39 out of the 40 patients rated them as good to excellent and just rave about it. In fact, one lady just came in. She had had this done. Another lady she met in yoga class had this done, and they were sitting there in yoga class discussing how good they looked and letting all the patients in the yoga class know if anyone ever got breast cancer, this was the only way to get it treated. How about additional systemic therapy? 36 patients were eligible for endocrine therapy. Now this is interesting. 4 elderly patients, about age 81, told me right up front that they would not take hormonal therapy. Some of these had very aggressive little tumors. Are you just going to get away with a lumpectomy? You know they're not going to take their pills. So if you can slip 1 good dose of radiation into these patients during the operation, then I think you've really gained them some leverage so that they can be comfortable and you have a little more than just a lumpectomy in following their treatment. And then 8 patients actually have received chemotherapy. So I think the follow-up now, we have 40 patients who've completed the IORT. My average follow-up is 14 months, ranging from 3 to 17 months. No patients have been lost to follow-up. Unfortunately, 1 patient has already died at age 57 of an unrelated cause. 1 patient has been diagnosed with lymphoma and is currently getting chemotherapy. And so far, we have no evidence of either local or systemic reoccurrences in any of these patients. So to wrap, this procedure works, at least technically, with 1-year follow-up. It does not take any more time. Patients get back to work immediately. No longer do we have the inconveniences of 5 weeks follow-up. We are getting margins. We are running the full gamut of additional systemic therapy. And I think it is too early to tell which patients are going to benefit from this, but I think with us carefully looking at things like the prognostic factors, the Oncotype DX score, that we will start to be able to analyze who will benefit from this as we get longer treatment or longer follow-up. So, cosmetically, this is typical of these patients at 1-year follow-up. This is 1-year follow-up. You can barely see where this patient had her procedure. And what about 2-year follow-up? I'm back to skiing.